This podcast was produced from a webinar. For a more interactive experience with visuals, visit myamericannurse.com/webinars.
Welcome. Thank you for joining us today for part 2 of Challenging and Inspiring Beyond Common Fall Prevention Practices. We'd like to thank Colette Health, who is supporting this webinar with an unrestricted educational grant. So let's get started. I'm Lillee Gelinas. I'm editor-in-chief of American Nurse Journal. I'm also an associate professor and the patient safety section director at the Texas College of Osteopathic Medicine, located in Fort Worth, Texas. Here are our objectives for today. Engage and inspire administrative, clinical, and quality leaders to adopt fall prevention best practices. Enhance current practices utilizing expert clinical knowledge to reduce preventable falls. Describe how to protect vulnerable populations from injurious falls. And identify the outcomes and clinical measures of fall program success which preserve patient function, independence, health, and quality of life. Now, there's a lot of information you'll learn today, but here are the key takeaways we want to make sure that you learn. Utilize clinical expertise to define fall risk factors for specific clinical populations, including those in the emergency room. You'll learn the difference between at-risk and known faller patients, congestive heart failure, transient ischemic attack, and hip fracture. Realign patient outcomes from fall rates to the mitigation and elimination of fall risk factors for preventable falls. Apply the nursing process to evaluate individualized patient responses to care planning, and integrate best practices as common standards of practice. We are so privileged to have the leading expert in fall prevention, Dr. Patricia Quigley. She's president of Patricia Quigley Nurse Consultant, LLC. She's well known as a distinguished fall and injury prevention expert. She's a prolific scientific scholar, published in multiple peer-reviewed journals. She's an impactful scientist, but I am thrilled to call her colleague. Dr. Quigley, take it away.
Oh, Dr. Gelinas, thank you so very much for that warm introduction and also opening up our second webinar together this year. I cannot tell you, Lillee, what an honor and a privilege it is to be with you and to be able to present this webinar with you. But I have to thank you for all you do for the American Nurses Association, for all nurses, for all populations in our great country, for being our chief editor of American Nurse, and also to thank you for all of your work, the journal, of course, but all of your work in patient safety. I just can't thank you enough. And colleagues, I am honored and delighted today to be here with you as we celebrate National Fall Prevention Awareness Week that started on September 22nd. I'm so thrilled that the American Nurses Association and Lillee scheduled this session with you this week because I know that you're already engaged in many activities for your community, your hospital, all your colleagues for National Fall and Fall Injury Prevention Awareness Week. And I hope that there are some of you who are joining us today that also were on the webinar with us on June 20th, our very first webinar that we did together, and moving best practices to common practices. So with this one, we do want to engage you, as you know, in clinical knowledge as best practices to reduce those preventable falls. But I want you to commit today for tomorrow, to commit to the most important patient safety outcomes. And that's what we're emphasizing on this webinar as we move into clinical practice, is that the true clinical measures of fall prevention success are mitigating and eliminating fall prevention risk factors, but also for those that can't be eliminated or mitigated, to be able to help patients compensate for them and to align these to preventable falls. So we're moving you into precision. So we want to ensure that you are going to devote preservation of each patient's function, independence, health, and quality of life, just as Lillee had introduced to you. So for those of you who were with us last time, I just want to re-emphasize to you, those of you who are learning with us today for the first time, that in 2018 in the United States, and this is estimated by the CDC, about 1 in 4 adults, 28% of adults over the age of 65 or older, report falling at least once in a year. And that results in about 36 million falls each year. But you know what? More than half of those who actually fall will not tell their provider. And that's why we're so committed on National Fall and Fall Injury Prevention Awareness Week to get the word out that we want people to tell us about their falls so we can help them. But you know what, colleagues, of those 36 million falls that happen, there's about 37% of those that will be injured. And we want to protect people from injuries when they fall because it's injuries that result in loss of function or loss of life. But among those 37% that actually have injuries, you know what? 37.5% of those will come into your emergency departments. And that is a huge burden into emergency departments. And we spent a lot of time on that on our first webinar. I hope for those of you who didn't attend that you will listen to that. But of those emergency departments, only 31.7%, even though that seems to be almost a third, will actually be hospitalized. So that 68.3% are actually sent home. So that's why we really focus on the emergency departments as a special area of priority for assessing and identifying fall risk factors. So of those who get admitted into the emergency department, there are 31.7% of those who actually come into the hospitals. But unfortunately, 3.4% of all of those who have fallen will have a death. So when we talk about hospitalizations, we are talking about those people who are sick or they have been injured, that they're actually being admitted. So that is our special priority focus for today, is helping you to individualize population-based approach to care. Because fall risk screening is not the same as assessment. In the emergency department, every older person who enters into the emergency department should indeed have a fall prevention care plan that started, but we don't want you to overlook the urgent with what's really important. Just because someone comes in with, having some complaints about having had some loss of balance and they really had congestive heart failure, we need to focus on those congestive heart failure issues, of course, because they're having shortness of breath and other medical issues. So always realize that you have to move from screening to assessment, because screening is only about history. Assessment is getting to those risk factors that need to be treated, mitigated, or eliminated, and to include functional assessment. So fall risk screening is not the same as assessment. But we do have to navigate those pathways. And what are those pathways? Those who get sent home versus those who get admitted. For those who actually get sent home, what we have on this slide, these are people, remember, who fell and came into your ER because of a fall. These are our known fallers. So for those who get sent home, the emergency department clinical staff absolutely will be reviewing the emergency department findings, but what we want to happen when someone gets sent home, and this is a priority for all of you in this National Fall Prevention Awareness Week, is to make sure that whatever assessment was started, multifactorial assessment that was started in the ED, that this continues on, but it includes fall and fall injury risk, and that we initialize individualized care plannings that will be followed up in the primary care setting, monitoring each patient's response to care, modifying their responses and changes to conditions, ensuring that everyone that you are involved with their care is a partner in their fall and fall injury prevention program, and that includes the family members. Providing that discharge plan that includes primary care so we can have continuum of care. It will be seamless with the reasons why they came in because of a fall. Referrals that should be initiated for patients who really require PT and OT. They don't need to be admitted, but they've got gait and balance problems, so we really should initiate that. I've emphasized for you the CDC STEADY program that's stopping elderly accidents, deaths, and injuries. There's all kinds of resources that we provided in the first webinar. So those of you, again, who are reaching out into the community, this should be an integral part of your fall and fall injury prevention program. And in the emergency department, if you have a chance to do a follow-up phone call to see about satisfaction, ask if they've had a fall since they left you. And if they say yes, then you should ask, have you told your family? Have you told your provider? Because remember that percent that won't tell their providers that they've had a fall. So this is really important. That follow-up phone call is to take every opportunity that you can to ask about that fall, because if you create the invitation, they're more likely to tell you. If you don't ask, people are not going to tell you. So engage your patients, engage them in the orders, educational materials, and all that you can with your primary care provider throughout the rest of the year. But what about those who get admitted into your hospital, who come into the emergency department and they get admitted into acute care? The patients who present to your emergency department because of that fall and they're being admitted, absolutely you want to know the etiology of their fall, because how you treat them once they get admitted and you've gone ahead and treated their injuries, if they had any injuries, and stabilized them, how you manage someone who fell because they were orthostatic is very different than someone who is hypoglycemic. That is very different than someone who had a balance loss. So look at those who are urgent or emergent. That's who's coming into your care. Then begin your triage. And your triage is screening for your risk factors, getting to the history of falls, medications, mental status, as you see here, but preparing for admission. And we've had shared with you the handoff tool that I have prepared that is yours for the making and taking and modifying for you. But this is who gets signage, the known faller. So those who get admitted. And what I wanted to do for you in this lecture, this webinar, is to focus on 3 populations that came into your ER, had a fall, or didn't have a fall, but presented to your ER that cannot fall again in your care. They cannot fall again in your care. So congestive heart failure, transischemic attack, and hip fracture patients. And you can come up with your own populations after you've listened to this session, if you will, based on those who present to your ER. But you know what? There's evidence-based fall and fall injury prevention factors for each of these populations that you can pull together through convening clinical experts. The case studies are a wonderful way to help you to develop assessment, care plans, and prevention interventions based on fall risk factors per populations for which 2 types of falls? The 2 types of falls that are preventable: accidental falls and anticipated physiological falls. Remember, you can't look at all fall rates and know what you're doing is making a difference, because the interventions are specific to a type of fall. So that's why I love case studies. So I'm giving you a start on clinical case studies that I hope that you will take this as a learning opportunity and continue this educational process in your own organization. So let's start out with our congestive heart failure patients. Those congestive heart failure patients, you know the predisposing fall risk factors that they have. They have exercise intolerance, they've got respiratory symptom problems, they sometimes have reduced cognitive function. They may even have orthostasis problems because of medications that they have been on, some dependency in their activities of daily living, maybe even some impulsivity, thinking that they can do more than they really think that they can do, which is the same as safety impairness, impaired safety awareness, overestimating their abilities. They may have some, if they have low oxygen levels, have some impaired problem solving, and even some incontinence that we could have with some of the symptoms that are going on. So when you think about congestive heart failure and the predisposing factors, I want to introduce you to your grandmother. So as I introduce you to our first case study, your grandmother has just turned 100 years of age, and yep, you know what? She's still smoking. She's cognitively alert, independent in activities of daily living. She walks with a cane that increases her stability. You know, she wears hip protectors because she's already had a hip fracture. And that happened when she was 92 years of age. And when that was when she was living at home. And after that, she moved into assisted living. So here she is now in assisted living. And I know for people that of this age, 90 and over, that the hardest thing that they can do is to stay independent. So she's been independent. She's on some her medical history is a little bit of, she has osteoporosis, coronary artery disease, irregular heart rate, a little bit of Lanoxin for that. And as I mentioned, the hip fracture. She's no longer driving. And she enjoys a shot of whiskey at night before she goes to bed. So after dinner on a Monday evening, she was getting ready for bed, and she was sitting on the side of the bed, and she started to have increased difficulty breathing, coughing and wheezing. And she was feeling even more tired than she usually does. So what she did is she called 911 and she presents to the emergency department, your emergency department. Now remember, she's over the age of 100, and what makes her even more special is she's in the population age group where if they fall, they die. So you cannot let her fall in your care, in the ER or in acute care. So she presents to you in the ER with excessive fluid in her body tissues. As you can see, she's got edema, ankles and feet, her legs. She's coughing and wheezing. She's short of breath. She's had some weight gain with this edema, some fatigue, increased heart rate. Her appetite, she's been nauseated. She's had issues with that, and she's feeling confused and just disoriented.
So you've seen this. This is your patient.
So you do that assessment, and you do the lung sounds. You hear the wheezing and the coughing. You know the shortness of breath. As you can see, all that's on the slide, that she's got that edema.
So we know she is going to be admitted. We need to implement a care plan.
So what I have done for you here, based on the assessment and the risk factors that you know exist with people who have congestive heart failure, but for someone over the age of 85 who's 100 years of age, is that you have to develop a care plan after your assessment to reduce preventable falls. Remember, we're talking about preventable falls. So that means you have to create a safe environment. When you create a safe environment, you're reducing accidental falls. You have to develop an individualized population-based fall prevention care plan for someone who has congestive heart failure based on risk factors inherent to what you just assessed. And that reduces anticipated physiological falls.
So what I have prepared for you, colleagues, is a care plan that helps align the interventions to create a safe environment to accidental falls.
And the interventions to treat the risk factors inherent to your grandmother to reduce her risk for anticipated physiological falls. There's always an interaction effect between environment and the person, but you have to separate out the interventions because there are different types of falls. And that's how you develop an individualized care plan, but also based on the reason why she's at risk for falling, the congestive heart failure. You could apply this model to someone who's diabetic or other medical conditions, but I want you to see that this is aligning the interventions to the known risk factors in an environment for someone with congestive heart failure versus someone who has risk factors inherent to their person. So for someone who's over the age of 100, to create a safe environment, you got to look at bed placement. You got to put her bed closest to the doorway, any doorway in the ER where she can be seen by anybody who walks by in the acute care setting, for anyone who's walking by her room. You've got to have a safe bed exit side, making sure that if she does have any kind of weakness, that if she gets up without you, she gets up towards her stronger side. You put her in a chair. You've got to put her in a high back chair. You just can't put her in a regular chair because she might slide out, especially if she leans forward for something. Use a bedside commode. Don't make her walk to the bathroom because she's going to be started on diuretics. So get that bedside commode. That is an intervention, creating a safe environment. Low bed position or stretcher position as much as you can. And what do you see there? A floor mat. You've got to have a floor mat to protect her from injury if she was to fall. But a low bed position is only going to reduce distance that they fall. Socks, these socks should be socks with shoes because she may have some foot drop, she may have some neuropathy, and you want to make sure that she's not in non-skid socks. But remember that O2 tubing? That's going to be a trip hazard. So all of those interventions that you see there on the left side of the slide are for those risk factors that are related to the environment of care, which is your responsibility to make safe when someone comes into your care. Now, to complement that, on the right side is the risk factors related to the congestive heart failure that we just assessed on the prior slide. You want to monitor her response to oxygen. You want to apply interventions that deal with energy conservation, maximizing her ability to function when she's feeling stronger or the oxygen level is higher, more appropriate. Completing small tasks rather than doing multiple long things at a period of time. Progressive moderate exercise, scheduled individualized toileting. You have to do that because she's going to be on diuretics, have some IVs going. So you have to set up an individualized toileting program. Medication monitoring. How is she responding to new medications that she's getting to treat her congestive heart failure? Making sure she has help with all her activities of daily living. And you know she's going to be anxious and she may even have some sleep problems. So I hope that you see that this is truly for a high fall risk population lady, your grandmother who's over the age of 85, who's 100. You have got to protect her in a different way than just anyone who comes into your care that is fall risk, a high fall risk. This is population specific, age specific, and diagnostic specific. So I hope this really makes sense because if you implement the interventions on the left side of the screen, you're protecting someone from having an accidental fall related to your environment. When you implement the interventions on the right side of the screen, you're reducing the risk factors inherent to her person. That's your individualized care plan, so that you are indeed
reducing the risk of unanticipated physiological falls. You have to have the precision, colleagues.
So you create a population-specific fall and fall injury prevention care plan for congestive heart failure patients. I've started it for you. You can take this, make it yours, trial it. Just because your electronic medical record isn't set up for this doesn't mean you can't do it. You can create a safe environment. You don't need to have an EMR checkbox to tell you that you need to create a safe exit site or bed height or a proper chair. But with these strategies, you have to monitor her response to care. You know, the bed positioning for the strongest side, the positioning aids to the safe exit sites, the frequent toileting, is it working? Do you need to change it in any way? Continence management, her respiratory function, you still have to be able to monitor her and her energy conservation. So I hope that this is a really great example to launch us.
So I'm moving you to the next one now. So here's your mother, okay? Your mother is coming into your ER, and you know why she's coming into the ER?
Because she's 65 years of age, she's married, she works full-time, and she's recently retired as a high school math teacher. But she's been having trouble coping with her retirement. She's only 5'5", 148 pounds. A little bit of hypertension, diabetes, osteoporosis. She's watching TV, and what happened? She's retired, and she starts having left side weakness and slurred speech. She's starting to have a right brain CVA. So, of course, she's being taken to the emergency department. And you know what? This is you. I know, just like my 100-year-old case study, I know that every one of you on this call in your hospital has this patient come to your emergency department. She's on the way to the ER, and her symptoms resolve. She comes into the emergency department.
And here she is with a TIA. Absolutely, she should be worked up for a stroke in progress.
Yeah, you're going to go ahead and start the stroke protocol. So you have assessment of onset and duration and symptoms. Your mother, you're doing neuro checks. She has anxiety. Oh my gosh, what's happening to me? Just retired. You're going to start talking about fall history, and she has no history of falls, but she's an impending stroke. And you're looking at range of motion, upper and lower extremity extremities. She's got some peripheral neuropathy because she's diabetic, and she has good sitting balance.
So that how she presents into the ER.
So you start an initial plan of care because she just had a TIA, and you have to anticipate changes in status. You have to anticipate changes in status. So as you look on the left side of this, what you're seeing is what we need to do to create a safe environment. Because you've got to keep her safe, and you've got to create a safe exit side or create a safe environment to reduce accidental falls right here. Look at all the interventions there. Everything that we have there, including even a stretcher sensor, because we know she's going to try and get up without us because you know what, her symptoms have resolved. And this is a true case that I've had one of my patients. I had one that was actually resolving and taken to the bathroom and left. And what happened is her stroke evolved in the bathroom and she was left alone. So this is creating a safe environment. On the right side of this slide, what you're looking at is things that we need to anticipate for. You need to still stay with her, contact guard assist, standby assist for mobility, because you don't know when that stroke is going to occur again. You've got to go ahead and monitor that blood pressure for a postural hypotension because she's already started on some medication for that hypertension, looking at her pulse, making sure that she's assisted with toileting, not getting up by herself, using that bedside commode if you need to. When you're starting medications, have her teach you back.
And always as a partner, so that this is the initial plan of care. This plan of care is going to change.
You know why? Because in the next hour, she has a change in status. She starts to have garbled speech. She becomes inconsistently able to follow commands. She's unaware of her impairments. We have that technology still there, sensory technology, because we know that things are changing, and she's inconsistently oriented to space, time, and sitter. So now we're going to go ahead and put a sitter on her.
Even though she is only 65, she has a changing medical status.
So you know the stroke risk factors. I gave you the beginning of an initial plan of care for creating a safe environment and reducing anticipated physiological falls that should carry on into the acute care setting. And then based on what happens as she evolves, this is when you start developing the care plan that deals with all the rest of these risk factors, because you know what, colleagues? A left brain CVA is not the same as a right brain CVA, and you can't treat them like they're the same. So that's when you use your clinical judgment, and you can build your care plan to create a safe environment, continue on into the acute care area, just like you would dealing with her risk factors inherent to her person based on the stroke that she has. But be sure you look and address all of these risk factors, because there is going to be cognitive impairment, impaired safety judgment, impulsivity, agitation. They're going to get up without you, and you cannot let her fall in your care. You cannot.
So you have to protect her in a very different way.
So you develop and you create a population-specific and injury prevention care plan specific for a stroke patient, left brain versus a right brain CVA, and the strategies to be able to monitor her response to care with the family. So you've got to do frequent reorientation, medication scheduling management, continence management, helping her with her ADLs, anticipating her needs. You have to do that. That is so important, because they're going to overestimate their abilities.
And ensure that you are dealing with differentiating from the left brain to a right brain CVA.
So that's a very important patient. She had no history of falls. She cannot fall in your care. Now, my third case study is your father, who gets admitted that has a hip fracture, falls at the bedside on an orthopedic unit. Excuse me. And you cannot, you have to protect a 70-year-old man differently than you do other people who fracture, because men who have hip fractures, and we know 95% of hip fractures are caused by falls, have worse mortality than women. I'm so sorry, I'm just having a little bit of coughing here. So we have someone who's come into the orthopedic unit, he's had a knee replacement, and sure enough falls and has a fall at the bedside and has a hip fracture.
So for your father, I'm handing this case study over to you.
Because I know every one of you on this call has someone who's had a hip fracture in your care. And you have to protect people from hip fractures, and that's men and women, knowing that 95% of the hip fractures are caused by a fall. So what environmental factors are you going to address to reduce accidental falls? What risk factors are you going to address, intrinsic and extrinsic, that are specific to physiological falls?
With someone who gets admitted to your unit with a hip fracture.
Well, I'm giving you some answers, but I'm giving this case study for you to take back to your hospital, because I know every one of you on this call has had someone who's come into your care because of a hip fracture, has fallen in your care and gotten a hip fracture. So I've gotten this started for you. Creating a safe environment, you've got to address the issue of a suboptimal height. You can't expect them to get up from a low bed. You've got to height adjust. You got to make sure they have their mobility devices. You got to address footwear. You can't put them in non-skid socks. You got to get that floor mat down. You can't let them break their hip again, fall on that hip. And you've got to talk about hip protectors to them, especially older people. Get them into hip protectors. Look at all the intrinsic and extrinsic risk factors that are related to an anticipated physiological fall. Pain, impaired mobility, decreased balance, decreased range of motion, altered ADLs, assisted toileting, medications, overestimating abilities. And you know that your father is going to overestimate abilities. Your father is going to get up without calling for help. I can guarantee it. So you know that as well. So colleagues, with each of these risk factors, your assignment is to take each one of them, accidental and anticipated physiological falls, and you develop the interventions for them. And do this with your team, with the colleagues that you have with you. Pull your experts together. Create a population-specific fall and fall injury prevention care plan based on hip fracture patients, along with strategies to monitor their response to care. All three of these scenarios, congestive heart failure, someone with an impending stroke that strokes out in your care, and then a hip fracture patient who comes in with a hip fracture or has a hip fracture during your care, these are really vulnerable patients. They're not just anybody who's at risk for falls. So my hip fracture patients, absolutely, as you see here, some things are similar to what you see with the other two case studies, our congestive heart failure and our your grandmother and your mother. But this patient has post-fall stress as well, fell and broke a hip, and is going to end up having to go to long-term care, short post-acute rehab, long-term care, and may or may not return home. We all know that scenario.
So do all that you can to be able to protect them.
So these best practices should be common practices, colleagues. Your fall for injury prevention program should be population specific, should have an individualized fall prevention care plan, should integrate injury risk. You've got the hip protectors and floor mats included in this lecture. You got to, set up program priorities for each of these. Protect from injury, protect. That's different than fall prevention. Protect from injury when they fall. realign your outcomes from fall rates to mitigation and elimination of fall risk factors. Can you imagine if we could say that? How many risk factors that were resolved because someone came into our care and they left us healthier with better function? Emphasize precise measures of mitigation and elimination of fall risk factors. Align them to the types of falls. But focus on measuring that you have been able to mitigate and eliminate risk factors, that you have been able to improve every patient who came into your care.
As much as possible, improve their function.
So you individualize the nursing process and you evaluate individualized patient responses to fall prevention care planning. We have to go from screening to assessment, which leads to diagnosis. You've got to include fall injury history and fall risk factors. Aligning the risk factor to the type of fall. Monitoring every patient's response to care planning, which I tell you is under completed in our healthcare system. Evaluating patients' responses to the care plan. Is it working or not? Are you modifying that care plan? This is not a paper exercise, colleagues. This is real life management of improving health and function. And repeat that, evaluate response to care, do rounds with them. How is your care planning
going? What are we learning?
What have we been able to do together to help you improve your function and reduce your risk for falling? So determine the specific outcomes. And my quest for you, not request, my quest is that you mitigate and eliminate fall risk factors. So today we have created population-specific fall and injury prevention plans based on diverse populations and populations based on diagnosis, along with strategies to monitor response to care. But there's other populations, and I ask you to select yours, the one that is of interest to you, because there are so many. I've given you 3 populations: your grandmother or great-grandmother, your mother, and your father. And it does get personal, colleagues. So I hope that this is helpful to you, because there is a clear distinction between screening and assessment for fall risk factors. The requirement for comprehensive multifactorial assessment is critical to individualized population-specific fall and injury prevention planning. So alignment of management to types of falls is so important, because the true measure of all this work is not whether or not they fell. It's improving their function and independence by mitigating and eliminating fall risk factors. So thank you so very much, and I hope that you'll share. I'm so thrilled to be with Lillee as we're together to help you as you move forward with your fall and injury prevention programs, because we know you're champions for change. And with that, I'll turn it over to you, Lillee.
Thank you so much for such a impactful, specific, and directions for us that we need so badly. I'd like to also help our audience with creating that sense of urgency for change, because Pat, you have certainly given us the direction, but I know that every clinical setting has financial pressures. So if we want to buy floor mats, if we want to buy sensor stretchers, if we want to buy more bedside commodes, for instance, it's going to cost money. And so what's the return on investment for advancing falls best practices? And I just want to give our audience just a couple of things to think about. Show the numbers, but tell the stories too. Pat, you did a great job with that. You told the stories of age-specific and population-specific care planning that we need to understand. The numbers are one thing, and you certainly expressed that in the beginning, but it's the stories that brings the sense of urgency for action. So when you're thinking about the cost of harm, think about beyond the human cost. Document that, understand that, the harm to the patient, the family, and the care team. Because remember, we as nurses, all caregivers, are second victims when there's an adverse event. And we can't exclude care for the second victim. So there is that human cost, but there's also the financial cost and the cost of reputation. Now, what do I mean by cost of reputation? You might not be aware of the Leapfrog Group safety grade system. It's been in place for over 20 years. You can Google your hospital, just do Leapfrog Group in your hospital and learn your safety grade. But what is your hospital doing specifically to ensure that you don't suffer an added injury from a fall while in the hospital? That's the message from the Leapfrog Group to consumers. What's the hospital, what's the care setting doing to protect you from a fall. Along the bottom of your slide here are the categories that the Leapfrog group uses to develop the safety grade. And look, patient falls and injuries and falls causing broken hips are publicly reported. Many consumers don't realize that, but as nurses, we need to be aware that we have the direct ability to impact the safety grade. A grade that is below average, meaning your hospital is performing below the care of other hospitals, that's in the red. If it's in the yellow, you're just average. And if you're in the green, you're better than average. What you don't want is to be in the red for anything, and especially when it comes to falls, because as Pat said, so many are preventable. So learn what your safety grade is and know that cost to reputation is publicly reported. So thank you for joining us today. Colette Health has provided our unrestricted educational grant so we could bring you this webinar free of charge. I also want you to know that all content was developed and peer reviewed and is independent of our sponsor and meets the strict criteria that we use to develop all of our American Nurse Journal articles. You see more about Colette Health on your screen, and I invite you to learn about their virtual observation technology. Also, be aware that this webinar will be available on demand soon. So I know you have a lot of questions. Type in your questions in the question and answer box, and Pat and I will get to as many as we can.
Absolutely. Thank you. Thank you so much for that information too, because the cost is, the safety balances out the cost. That's for sure, is a priority.
Absolutely.
Thank you.
So, Dr. Quigley, let's get to some of these great questions. You talked a lot about population-specific care planning. So how should we go about selecting just one population to develop an individualized care plan around?
Well, Lillee, that is such a great question. Thank you so much to our audience for asking that. And, you know, the population that I would encourage you to select is when you look back in the last year and see the population that's had the highest number of falls and the unit that that population belongs to. And what I want you to think about doing as you do that is your ability to be able to bring experts together that have clinical practice expertise in that population and start working them up and coming together and deciding on what are those environmental risk factors and what are those risk factors, you know, inherent to that population. But select it based on a diagnosis or indeed a population. Maybe you're new mothers. Maybe that's the population where you're having more of your falls that are occurring. So look at the population, but make sure that it is those who have been falling so that you can do everything you can to be able to protect them. And we would love to hear which population you select. I still emphasize people over the age of 85. And I tell you why. Even though that's age specific, it's just people over the age of 85, we know when they come in our care that they have to be treated in a very different way than just anyone who's high fall risk, because we know that if they fall for any reason, any type of fall, that they could have loss of function or loss of life. So that is one that I really ask for you to consider, because that's who I'm trying to protect, those at the tip of the pyramid where they're at greatest danger if they fall in your care. So that's one suggestion, a second suggestion that I would make to you, but that's a really great question.
Sure is. You know, Pat, we get a lot of feedback from nurses about the barriers to implementing best practices due to the electronic medical record. And have you seen that specifically? And if you have seen the barrier to nurses trying to implement some of these best practices, but what they have to document in the EHR. So what recommendations do you have for change? How can we overcome this EMR barrier?
Oh, that's a second great question, Lillee. And I tell you, I'm so glad this question came up because I have found in my experiences that the electronic medical record has really been a barrier for nurses being able to document things that they think are clinically relevant to the situation of their patient. We don't want to have checkbox mentality or processes for our documentation. So what I would suggest is that you, with your clinical practice committee, with your shared governance model, with your IT specialist, is ask for change. And I want to say to you to demand different, demand it. We have to be able to say that change is possible. So ask for it. And then what I would suggest to you, once you bring these people together, is to start with one change at a time. I know it takes a lot to be able to change your electronic medical record, but maybe you want to do something about how to guide the practice of postural hypotension. Like maybe you have already embedded in your electronic medical record for doing neuro checks. But do something, pick one thing that's going to result in the change in your electronic medical record and make it happen, realizing that whatever you take on, like postural hypotension, it's going to involve more than just the EMR. It's going to be a commitment to this clinical opportunity for a fall risk for your patient population, developing the policies and the procedures, making the change in the EMR, doing the education and training to make that happen, implementing it, and then monitoring how it's actually being documented in the EMR, and does it translate into the care plan. So even though I'm suggesting one change in the EMR, there's a lot that goes to systems change to make that happen. But pick something. Or maybe besides postural hypotension, you'll think about integrating risk for injury, because still I know a lot of organizations are not asking just about fall history, but they're not asking about injury history or injury risk as part of the admission assessment process. So pick something, bring people together. That is, both of those are aligned to all of the drives for individualized fall prevention and getting to mitigating and eliminating risk for falls as well as injury. So I hope that that's a great answer to be able to help guide you to making some change and making it happen. But don't let there be barriers, that this is something that you really want to do. So thank you for that question.
And I would add, you say commitment to best practices. At the end of the day, this is commitment to clinical excellence. So
it is. And using clinical judgment. So we can use our clinical judgment.
Absolutely. Questions, Pat, are rolling in, and I'm going to get to as many as I can.
Excellent. That's
one
great.
Question. Have you seen specific criteria for hip protectors? We struggle with the right patients and the right interventions. So talk about hip protectors.
Oh, absolutely. Hip protectors are for those people who indeed are fall risk, I mean the high fall risk, but they've already had a history of falls and they're osteoporotic. So the hip protectors are people who've already had a hip fracture, they're osteoporotic, and they've been falling. But, you know, based on the DEXA scans and their osteopenia or osteoporosis, those are who you want to protect. And you know they've got significant like gait and balance problems because you know they're going to fall, but you want to be able to protect that hip. So it should be based on fracture risk and also fall risk and fall history.
Great,
or someone who's already had a hip fracture, colleagues, and they're older and they're coming into your care. You should at least talk to them about it and help them be able to know that there's hip protectors out there that can prevent them from having a hip fracture if they fall again on that lateral side.
Here's one, Pat, that's near and dear to both you and me. What is a good way to implement these practices to newer groups of nurses, those novice nurses, who seem to be much more task or work list centered?
Oh, the ways that I would do that, I would start doing case studies and making it personal. You know, when you bring people together, you will find that there's people who have struggled with patients who have fallen, or struggled with patients who have been resistant to following some of the recommendations that you're making, or maybe even in their own life, that they've had people that have fallen in their own life and had injuries. But I would bring people together, do your case studies. And then another opportunity for going from case studies and working through case studies and interventions that have been implemented and have worked is try doing some fall rounds on your unit, you know, with your novice nurses, and make it come alive. You know, I've implemented fall rounds on medical surgical units, and they've really taken off, where you go over the care plan. You know, how is the care plan working? What are you learning? Is there anything else we haven't covered yet that maybe is a concern for you about your concerns about falling? And when I designed it, it was to be implemented at least once during someone's episode of care. It's not like rounds that you would do for rounding, you know, for potty, pain, those kinds of things. but a care plan around about their fall care plan and how is it working, because you want people to be partners in your care plan. And, patients and family members love that, to have this conversation, because a lot of people worry about falls and they won't talk about it. But when you make it come alive and you really see working with your patient as a partner, that is actually making a difference, and that their gait is improving, their balance is improving. We've been able to adjust some medications. We're helping to do everything we can to adjust your blood pressure. Things like that, I think that's a real great opportunity. What do you think, Lillee? Because you've addressed that as well.
I have. Bedside shift report. I loved it when you said integrating the patient and family into the conversation. And for those hospitals that do bedside shift report, especially with new nurses, it's a great opportunity to have that two-way dialogue, involve the patient and family, develop the sense of urgency with the patient and family, not just with the staff.
Absolutely. And don't talk about high fall risk. Eliminate that from your discussion. What you talk about is what are the risk factors and the injury risk and the care plans and the interventions, but don't talk about high fall risk anymore.
A great answer. All right, so here's one. Do you see many fall policies around protecting the staff from injuries, as well as when a fall may happen, such as when they're on the floor, and if it's one nurse there, how should she respond to get the help? To help get the patient, I'm sorry, it keeps flipping. So let's just talk about protecting the staff.
Well, that is such a great question too, Lillee, because, I had said to NDNQI quite some time ago when they were really promoting assisted falls. And we know with assisted falls that we have less serious injury of the patient, but I always said that there was a balancing measure to assisted falls, and that balancing measure is staff injury. Yeah. So what I like to share with all of you is that there is emerging evidence that came out of the University of Nebraska that if a patient has an assisted fall with a gait belt, and this is a plug for using gait belts, is that the severity of injury to the patient is less. But what we don't know is the severity to the nursing staff. So I would still say that it is protective, because therapists use it all the time, OTs and PTs, but to use your gait belt. But that should be something that you really do follow through with trying to collect information about, because nurses won't say that they're having back pain as a result of lifting patients, but make sure that those patients, overprotect yourself. Go ahead and make sure that if someone needs, that you worry that they need two assists, that you have them two assists to be able to help someone. And recovering patients from the floor, don't be afraid to call a rapid response team and get people there to be able to help you, be able to help someone recover from the floor. I know that there's some equipment that can be used to help with that. But do everything you can to be able to protect yourself. And if you need to do some refreshing about the biomechanics of assisting patients during an assisted fall, there are some videos for that on the University of Nebraska program, the CAPTURE program. It's CAPTURE, that have some great videos by Dawn Veneman. It's VENEMA. She's a great physical therapist that can help you and your organization with that.
What do you do if you don't know why the patient fell? In other words, the unwitnessed fall.
Well, 80 to 90% of our falls are unwitnessed. That's why you got to do the post-fall huddle. So the post-fall huddle is where you come together to look at the environment with the patient where they fell and try and figure out what just happened, because you're trying to get to the root cause of why they fell. So the root cause, when you look at the Swiss cheese model, there's lots of ways for us to fall. That's when all the holes in the slices of the block of Swiss cheese align. When they all align, we have the fall that happens, because most of the time we have barriers that help prevent that fall from occurring. So what you want to be able to do is to find that protective barrier that fell through. So with the unwitnessed fall, you got to look at the environment, talk to the patient. The post-fall huddle should always be done with the patient, and ask the patient, what was different this time you were doing this activity compared to all the other times you did it and you did not fall, but this time you fell. So you're trying to get to that barrier that fell through. If it's a patient who is not able to talk with you and discuss this with you, someone who's cognitively impaired, then you do the best you can, because you can tell an awful lot just when you go in and you rescue someone. Look at the entire environment. You can see if they got their foot tangled up in the blankets or the sheets. You can see if maybe they slipped on something. So that's what I would help you to be able to really work through that post-fall huddle and make sure you're doing it right. You got to do it with the patient, look at the environment where they fell, and then try and come up with the immediate cause of why they fell.
Great advice. We have a couple of questions around alarms, alarm fatigue, and let's start with this one. What are your thoughts on overuse of bed alarms? How can we move away from that?
Oh, please do that. Please move away from
I
bed
knew what
alarms.
you were going to say.
You know, any intervention that you implement for a patient should not be based on a score or a level of risk, low, moderate, or high. I cannot tell you how many organizations I work with that they put a bed alarm on someone just because they're high fall risk, and then you're overburdening the nursing staff with alarms that are going on, but it's not relevant for a patient. So you're putting them on patients who are cognitively alert. There should be clinical criteria for any intervention that you implement. So for a bed alarm, your clinical criteria would be patients who have cognitive impairment and patients who can move. If they've got cognitive impairment and they can't move, then they're not going to fall out of bed. So that, you know, you got to have two criteria: people who are not going to be a full partner in your fall prevention program, and people who can't get up out of bed. So those are the people who should have a bed alarm. So, and then when you put the bed alarm on, that, remember, it's not for high risk, then you're going to use it as a position sensing alarm. It's not a bed alarm to prevent falls. What you want to do is to totally redesign this. The reason why you're using bed alarms is for position sensing, so you make sure that the patient has an assisted bed exit or an assisted chair exit. You're changing the program purpose for a position sensing alarm. And then you decide on what setting you want to set that alarm. Do you want it to alarm when the patient moves off center? Do you want it to alarm when the patient gets to the edge of the bed? You don't want it to alarm after they're off the bed. Because what did I just tell you the purpose was? An assisted bed exit. So we're going to set up a whole new goal. We're going to repurpose the program, and we're going to redesign the use of these alarms. And for those of you who are on the call today with long-term care, I'm telling you, an alarm is not a restraint. You use it as a position sensing alarm. It's a team decision. And you make the goal that we're going to improve the percent of assisted bed exits. We're going to stop talking about unassisted bed exits. We're going to focus on making sure we get there in time. And those people who need it, it's not everybody, colleagues. Remember, it's not everybody. But for those who need it, we're going to make sure that we get there in time. And we're going to have a goal that on this shift, 95% of our patients whose alarms went off, we were there in time and they had an assisted chair or bed exit. I think this is resonating for people because I can see some hearts or something that are floating.
So, you know, hospital policy, and depending on what type of tools that you use, you can make the argument that just about everyone in the acute care setting is high risk for something. And so it really is important to embed in policy exactly what you're talking about, the process, and then move it into practice. But I have seen this everyone is at risk for something.
You know, it doesn't work because, you know, like when that happens, everybody's being treated as if they're the same, and you've lost the pyramid. The bottom of the pyramid is everybody's at risk. Of course they are. And then there's those that as you move up the pyramid, they've already fallen. So they're the known fallers that we talked about in the ER session. And then you get to the tip of the pyramid are those people that are at greatest danger. You know, we don't risk adjust. I mean, there are patients who come into your care and they're at greater danger if they fall. So when you get to the tip of the pyramid, you got to protect them in a different way than just anybody who's at risk. So you have to risk adjust. And then when you get to implementing some of the interventions that we've talked about, the hip protectors, the floor mats, those are people that you're protecting that if they do fall in your care, you just don't want them to get injured. But when you start adding it to everybody, like a bed alarm on everybody because they're high fall risk, all you're doing is implementing universal fall precautions, and they don't work. They don't work. And then you have patients who are upset because they got these alarms on them going off and they don't really need them. So you're not going to put them on me when I come to your care because I'm cognitively alert, functionally independent, and I am going to be fiercely independent. So, but I love these questions, don't you?
Oh, yes. But I want to just add to what you said. That's why population-specific strategies have got to be embedded in policy as well as in practice. Let me try to get to a few more.
Just like our mother scenario, you know, a right brain CVA is very different than a left brain CVA. You can't treat them like they're the same. You just can't do it. I mean, if you're doing that, then you haven't built clinical competencies.
We screen more for risk of injury and not necessarily risk of falling. So what's the best practice for screening?
For risk for injury?
We screen more for risk of injury, but not risk of falling.
Well, if you're already screening for injury, then you should be assessing for risk of injury. If you're already assessing for risk for injury, you should be assessing for risk for falling, because people don't get injured unless they fall. So you want to make sure that you're getting all of the risk factors that are associated with falling, because and not be relying on these screening tools. You got to work people up. You got to do a functional evaluation. You got to do a physical evaluation. You got to work them up, because you want to mitigate and eliminate those functional risk factors, because when you do that, then you're improving their function, their independence. If they don't fall, they're not going to get injured. So you do want to work on falls, but remember, like in the scenarios that we presented, you've got to do everything you can to change the environment that best fits that patient, and that's different. And then work them up for their risk factors. But when they come into your care, it's not their home. So they are at risk just being in your environment. So that's why you got to set the environment up, you know, the safe exit sides, looking at their ability to even be able to navigate getting to the bathroom, on and off the toilet, things like that. So look at the environment and make sure it's safe for them. You should even evaluate, are they even safe to go to the bathroom? There's some patients that are not safe to go to the bathroom, so that's why you use a bedside commode. But even that, you have to make sure they're safe on it and can be left alone. I have a patient now that was left alone on a bedside commode who had a stroke. You can't do that. You can't put a stroke patient on a bedside commode and leave the room. You have to stay with them, because she fell off the bedside commode and fell with the bedside commode. So do everything you can to create a safe environment and then work that patient up. You've got to prevent falls. They are rare, but if they do fall, you just want to make sure that they don't get injured. So good job on assessing for risk for injury, but you got to look at risk factors for falls.
There's a question here. I'm not so sure I'm familiar with the Hester Davis Fall Prevention Program. So how do you feel about the Hester Davis Fall Prevention Program for this population?
It's a best practice. The HD nursing is a best practice, the Hester Davis. And that's Dr. A.B. Hester's program. Probably many of you have heard about that. Actually, it's embedded. The core variables of the HD nursing are embedded in EPIC, but it's not completely operationalized. It doesn't have the interventions. But it is the only tool that's actually been validated in the electronic medical record. It has the fall risk factors, and the only tool that actually aligns interventions to the fall risk factor. So I'm an advocate of it, but it's also been operationalized and validated in the maternity population. Ambulatory care for the ER is designed to triage, not to do, triage. We talked about that actually in my article that I wrote that's in American Journal. So, look at that. I really encourage you to see what's possible. If you're able to consider something, see what's possible. It's implemented virtually. And it has really spread, but it is the best practice model that's out there, the only one validated in the electronic medical record.
I really want to encourage our audience to read your article in American Nurse Journal. And I also,
thank you.
I want the audience to also look at that resource section of your screen, because Pat, you provided us with a tremendous list of evidence-based articles and resources so that our audience can make the business case around implementing best practices in their own organization. So before you leave the webinar, make sure you've downloaded the resource list.
Oh, thank you for promoting that, but also our Viewpoint article that just came out.
That's true. That's right. How can new technologies such as motion sensors and artificial intelligence be integrated into hospital fall prevention protocols to improve patient safety while respecting autonomy?
Oh, I love that question. That is such a great question to our colleague who presented that. And I really support it because, we're not enough. Nurses are not enough. We have to have some help, and technology helps. There are some patients where we need to have someone with them all the time, and we don't have enough resources for that. So I think the technology is very valuable to us, but I think that when you're focusing on autonomy of your patient, to be able to be upfront about why you're using this technology, to be able to help us ensure that you have restful sleep, that we can keep eyes on you while you're asleep, at the same time realize that if you're starting to get up out of bed, we can call someone to get there with you, to respond to you without when knowing that you might have trouble using the call bell, some scenario like that where you're actually engaging them about why you're setting up this technology. And then in using the technology, I would do everything you could to look at the innovative technology that's out there that's not alarming in the room. You want to have it connected. You want to have it wireless so you don't have any trip hazards, and you can eliminate some of these wired systems. But to connect it to the nurse call system, so that it's not alarming in the room. You don't have the alarm fatigue, but also for nurses to know that when the alarms are going off, that they know exactly who that patient is and they can get there right away. You know, with a lot of our systems, we have alarms going off, but we're not quite sure where they're going off unless it's connected to those lights that are outside the room. But you want to make sure you've got precision and being able to be aware of who has an urgent or emergent need. So those would be the suggestions that I would suggest, but I absolutely support using technology at the point of care to be able to complement practice, not to be able to substitute practice, but to be able to complement and help us.
Well said. Dr. Pat Quigley, thank you for sharing your expertise with us. Famed fallologist, as we would say.
Thank you.
And we've learned so very much from you. I'm sorry.
Well, could I just answer one more? I see one question in there. I just want to comment on that. Someone's considering these predictive fall tools in the EMR. I just want to help you think through that. Think about doing that, because the ones that I've seen, they have gone ahead and thrown all these variables into the model to be able to develop this, and it's just like fishing. There's no better predictor of the risk of someone falling than clinical judgment. They're going to be rolling out these information. It's not going to change practice. I just had this conversation just earlier today with a hospital organization. Really rethink what you do that adds to the burden of nursing that is not value added and it's not going to change practice. So pull back. Anything that Lillee and I ask you to do, we are taking something away because there's already too much burden on the nursing staff that takes them away from the point of care. So thank you for letting me answer one more question, Lillee.
And I would just add that what I've seen is those predictive fall tools in the EMR are making everyone at fall risk. And so if everyone's at fall risk, then we just aren't.
And it doesn't drive practice.
Not implementing population-specific practice. We really are out of time. Thank you, Dr. Quigley. Thank you to hundreds in our audience that have joined us. Remember, this webinar will be on demand at myamericannurse.com very, very shortly. Thank you, everyone, for joining us. Bye-bye.
Thank you so much, Dr. Gelinas. Thank you.